Not only have we seen the reports, we've seen the patients. We have seen a tremendous rise in the number of people that are presenting with addictive type complaints, whether they are seeking treatment or they're actually having physiologic manifestations of their addiction. So we see the spectrum of people that are here for near death from an overdose. Unfortunately, we've had some that have actually died from overdoses. We've seen people that are presenting voluntarily for help with their addiction. And we have other folks that have other injuries, such as a fall, and we then subsequently diagnose an addiction or a problem that led to that condition that caused them to present. So in the setting of a patient that is acutely overdosed, especially with opiates or with heroin, the big thing that we watch out for is respiratory depression. So these patients will have a decreased respiratory rate, and in those situations, our field personnel, such as our emergency medical services and our fire department, first responders, can administer medication to reverse the effects of the respiratory depression from the addictive substance. So in those situations, obviously, we're looking at life and death maneuvers to prevent any disastrous consequences from the overdose. We also see patients that come in with realizing that they have an addiction problem. And in those situations, our protocol is that we evaluate them to ensure there's no medical condition, and then subsequently we will refer them to the psychiatry or behavioral health services so that they can get the resources that they need to help them with their addiction. Sometimes that means they have to be an inpatient. Other times we can get them in a focused outpatient setting, and that determination is made in collaboration with our behavioral health colleagues.
Naloxone is one of the most important drugs. We have to have that on our trucks for all ambulance services. It's one of the requirements that we have to have this medication. And we actually did recently have we've actually had several saves. Just recently we had one. She was in cardiac arrest when we arrived. We put her on an AED, and once the ambulance got there, they immediately pushed the Naloxone, and she's still alive today. We have standing medical orders that our medical doctor has signed off on, so we can push these medications in the field prior to having to call in to a doctor and get permission, more or less. And the best part about Narcan is if we have someone that's not responding to us, we can utilize this actually to rule out. So if they've not taken anything, it's not going to harm them per se. It will be one of these medications that they've not responded to the medication. So this right here is how it's stored for EMS, and this is what we utilize. And the dosage on this, we start off with very minimum because it does metabolize very quickly. And then I'll show you this. Once we open this up, we can give this different ways. We can give it intramuscular if we can't get an IV, give it IV, and then we can also give it intranasally. So those are the different ways that we can actually give this medication. And from here, you just pop these two tops and screw this in, and you're ready to administer the medication. Normally we look for people who are unconscious, unresponsive, and they cannot protect their own airway, or their respirations are very low. So if we don't give the medication, then they'll actually end up dying.
Well, the medical amnesty bill passed on April 24, 2014. What it entails is it provides immunities for individuals looking for help, medical assistance in a drug alcohol overdose. And it includes, under 4 grams of a harder substance, under an ounce of marijuana, and just basically limited possessions that protect users that are seeking help. It also deals with the over-the-counter distribution of a drug called Naloxone. So far we've had over 300 opioid reversals in about a year and a half. Naloxone has a 99% success rate when administered correctly. Basically what it does is it coats the neurons in the central nervous system, and it's an antagonist. It goes straight to the neurons, and the naloxone is picked up by these neurons as opposed to the codeine. And so for about 30 minutes to an hour and a half, you have a window where you bring this heroin overdose back from the brink. It's literally day and night, raising the dead, I guess you could say. What we find with heroin overdoses is most people don't die from the toxicity of heroin. They die because their CNS system is so depressed that they forget to breathe. And so this brings them right out, brings them into a, sober minds. So basically we have a IV kit for naloxone. This is the needle. What's good about this is we actually get the horse needle, which users do not like to use for injection, so they actually will save the needle for the naloxone kits. For what I've been told is this actually will go through the vein. You see how long the actual needle part is. So basically, somebody who's been trained, takes about 2 or 3 minutes to train somebody. You stick it in there, you get the naloxone out. We pass out in our overdose prevention kits 2 vials of naloxone. Generally, an average heroin overdose will take 1, probably 2, maybe 2 if there is something called fentanyl in there. But you bring it in there, pull the syringe out, and then you go for the arm, which is closer to the heart, so it gets into the blood system, circulates, and then gets to the blood. It takes about 30 seconds to a minute and a half before the user goes into instant withdrawal. And it's actually very painful for the user. I don't know if you are familiar with withdrawals from opioids, but it's not a pleasant experience. Yeah, pretty bad. But it saves lives. You can't overdose, you can't get high on it. The side effects, say if I were to perceive a benzodiazepine overdose, I would, if somebody had taken Xanax, for instance, and I thought it was an opioid overdose and I gave them naloxone, the side effect would be that I hydrated them.
And Suboxone is similar to Methadone, but there's a couple added benefits. It lasts even longer than Methadone. I take it once a day in the morning, and it definitely lasts at least 24 hours. You can't get high while you're on it. The way that it works is it binds to the receptors in your brain a lot more strongly than pretty much any other opiate. So if you do try to shoot up or take some pain pills, they're not going to do anything because the Suboxone is already there and it's not going anywhere. I take my Suboxone, and this is what it is. This is the little package that it comes in, and this is what it looks like. Basically, it's just a little film strip, like Listerine breath strip. Instead of putting it on your tongue to dissolve, you put it under your tongue. So sometimes people cut it in half because this is kind of big to fit under your tongue in one piece. But within 10 to 15 minutes it dissolves. And like I said, I don't really notice when it takes effect. Usually it starts working if you say it's your first time taking it. Usually starts working within 45 minutes to an hour. A lot slower to take effect than heroin or even methadone. So there's really not any potential for abuse because you don't get a high, you don't get a rush. It's just kind of like, oh, I'm not sick. And even if you don't use it and you take it, it might make you feel a little warm and fuzzy, but definitely not near the effect that heroin or even pain pills like Vicodin or oxycodone have.
Methadone is a medication and it's used. A lot of folks are concerned because it's a synthetic opiate and they wonder, why are you giving a synthetic opiate to someone who has opiate addiction and dependency? The best way to answer that is we're dealing with 2 components really. The addiction is handled with counseling. There's a counselor that handles the addiction part. Methadone is a medication that treats the dependency part. What's happened to the body? We have natural opiates in our system. A lot of folks don't realize that, but we have natural opiates in our system. And when a person takes an opiate, it plugs into those natural receptors that we have and it relays certain messages. And once a person has taken for so long, the chemical kind of has an imbalance in the brain and the body system of that individual. So if they stop taking the opiate, 3 things happen. Number 1, they're no longer putting an opiate in their system. They've stopped the intake. Their natural supply is now low because they've been over-supplementing. And because of those 2 things, the 3rd thing happens is glutamate is being released. That's a negative chemical in the body. So that's what sparks what's called withdrawal. A patient will go through extreme symptoms for a lot of them. We're talking the digestive tract's involved, nausea, diarrhea, vomiting, shakes, anxiety, depression. There's 3 main forms that you usually see with methadone. One is the little white pill that pain management uses. The discus or the wafers are usually for medication-assisted treatment facilities, and the liquid is usually for medication-assisted treatment facilities. A lot of folks and a lot of us who look at this don't realize, hey, wait a minute, the dependency is what the medication is treating. So a person may be able to handle the rest of the addiction and getting things in order, but the body needs this medication to function, to balance out, because to identify the patient, their needs, and the best medication for treatment. That's key. And that's the big thing about educating folks about the different medications, the different options that are there, because it's not a one-size-fits-all.